Hello, everybody. So this is the lecture on pharmacology and medications. This is a long lecture. It's about 92 slides, but I'll try to get us through this as painlessly as possible. But this is a very important lecture because you're going to need to know these classes of drugs and these names of drugs, especially if you're working inpatient. But even if you're working outpatient ortho, your patients are going to be on prescription meds, either for their injury that they're seeing you for, or their condition, or for other comorbidities. So you're going to need to know the side effects and how these things interact and how they change exercise, the body's response to exercise too. So that's why this is important. So let's get through this as painlessly as possible. It's not too bad, I promise. I've forgotten how to screen share. Okay. Here we go. Okay, so pharmacology means the study of drugs, as you probably already knew. When it comes to pharmacology, pharmacologists and pharmacists look at two different things. They look at pharmacokinetics and the pharmacodynamics of a medication. So pharmacokinetics, think of kinetics means movement, how the body deals with the drug. So how the body works with absorbing the drug, distributing the drug around the body to various organs where it needs to go, and then to how the body eliminates the drug. So think about kinetics, moving around the body. Pharmacodynamics means what the drug actually does to the body, and not just what the drug does to the body, but how it exerts its effects. These are just a few general definitions that you probably already know. So I'm not even going to name those. And you know these too, but I'm going to just mention them real quick. So every drug out there on the market, and I'm talking about legal drugs, drugs that are used in medicine, drugs that you buy over the counter, drugs that are prescription, anything like that. Everything has three names. It has a chemical name that is given to it by the chemical structure of the molecule. Then it has a generic name, and then it has a trade name. So what are the differences? So chemical name, like I said, is the structure, is the name given by chemists, pharmacologists for the structure of the molecule or the drug. The generic name is the official name of the drug, and it's often very similar to the chemical name. So if you look at this example here I have on the slide, it says acetaminophen. Well, acetaminophen, its chemical name is N-acetyl-P-aminophenol. Well, that is its N-acetyl-P-aminophenol is its chemical name. Acetaminophen is its generic name. And its trade name, which is the brand name, is Tylenol. So if you pick up a bottle of pain reliever, if it's generic, it might not say Tylenol, it might say acetaminophen on it. But if you pick up a bottle of Tylenol, brand Tylenol, it'll say the word Tylenol on it in big, bold letters for the brand name, but then under that, it say acetaminophen too. So that's how those work together. This has always been and continues to be a source of confusion and error in the medical field. Different drugs have many names, and some clinicians may know others better than others, some better than others, and then mix-ups can happen. People get confused. They may know the generic name and not the trade name, but they may know the trade name and not the generic name. So there's lots of source for error with this. Let's see, generic versus brand name. For whenever, so what usually happens is, what always happens with a new drug is that a pharmacy company or a pharmaceutical company, I mean, will make a new drug and patent it, and then that drug has a generic name. And then after so many years, that patent on that drug expires, and then other drug companies can make it under the generic name. Well, they're making the exact same secret formula that the first the first pharmacy company had, but they've got to prove that their generic is exactly the same. So that's what bioequivalence is called. So it's got to have, the generic has to be proven to have the same type and amount of the active ingredient. So the main ingredient that does what you want it to do in the body. It's got to have the same administration route. It's got to have the same kinetic profile, and it's got to have the same therapeutic effects as the brand name. Let me fix my video really quick. Sorry about that. Okay, there we go. Sorry, my camera went away. Let's go back to where we were. So bioequivalence. So they have to prove that the generic drug is exactly the same and does the exact same things and is expelled the same way from the body as the brand name drug. And it has to do the exact same, have the exact same effects on the body as the brand name drug. Now, even when bioequivalence is established, there's still nobody, even the FDA, can give a guarantee that the generic drug is going to respond, or the body is going to respond exactly the same to the generic as it does to the brand name. Now, almost always it does, but there are some cases when generics and brand names of the same chemical compound will react differently with the same person. This is the FDA approval process. I'm just going to let you go through this chart. You do need to know these things for tests, but these are the preclinical testing in phase 1 through 4 trials and the specific things that happen in the trial. So you do need to know this for tests. These are the different schedules of controlled substances, and a drug schedule is categorized by the potential for abuse. So it goes from Schedule 1 is the highest potential for abuse all the way down to Schedule 5, which is the lowest potential of abuse. Even though Schedule 5, even though it is the lowest potential for abuse, that you can overdose and you can have bad effects from these, and you can actually die from a Schedule 5. So just because it's not as dangerous as a Schedule 1, you can still overdose in high doses on a Schedule 5. You can, I'll let you look at some of the different examples through here on this chart. Okay, drug therapy. So the dosage, you know what the dosage is? Well, you want the dosage to be large enough to produce the desired effect, but not so large that it produces a toxic effect. Because almost every medication out there, if we took it in large amounts, it would produce toxic effects in our body in one or more organ systems. So you want the dosage. They figure out the dosage during trials with animals and then humans finally to figure out what the least desired amount of chemical to get that specific desired outcome. The ceiling effect is the dosage at which no further increase in response of the body occurs in response to larger increases in the medication. So let me simplify that. That means the ceiling effect is when if you gave more and more and more of the medication, the body's not going to do anything different. So it's reached its maximum efficacy. You can scan over these terms, but these are just for your information. Okay, these are the different routes of administration, which I don't have to tell you all of these. One that I do want to remind, and these are all the routes of administration, with oral probably being injections being the ones we're most familiar with. I do want to remind you about transdermal, because that will, if you remember, an example of that would be iontophoresis. So that's an example of a transdermal medication that we would actually be administering. So that's the only medication we can administer is if it's through iontophoresis. But that would be a transdermal administration. These are the different intestinal or oral routes you can see, oral, sublingual, and rectal, and you can see the advantages and disadvantages to each, and I'll let you read through that chart. And besides this video, you do have this PowerPoint on Blackboard, just so you know. Here are the rest of the routes of administration. These are not oral or through the intestinal tract. So these are inhalation, injection, topical, and transdermal. Okay, so for every type of drug, there has to be a drug receptor on the specific cells where it's so that we can get it to produce its desired effect. So the receptor is a special place on the cell that binds to part of the medication molecule and sets a chain of biochemical reactions in place. Okay, so these are located on the surface of the cell, the outer surface of the cell membrane, and then most of them are, well, I shouldn't say most, many of them are surface receptors on the outer surface of the cell membrane, but some of them are intracellular receptors, where the receptors are located inside the cells. So some medications bind to surface receptors, others are taken inside the cells, where then they bind to intracellular receptors. So surface receptors here, they can act to open ion channels and alter cell membrane permeability. They can act enzymatically, and they can link up with other proteins to cause other processes within the cell. And then they're like messenger chemicals then. Okay, so now we're going to talk about, that's all on the basics of pharmacology. So now we're going to look up the different classes and a few different examples of many different types of drugs. So we're going to start off on anesthesia. Okay, so general anesthetics versus local anesthetics. Okay, general anesthetics cause reversible central nervous system depression and unconsciousness. Okay, they're used, it's most commonly used in surgery. The most common type of anesthesia used in surgery is general anesthesia because it knocks you out. The route is either through inhalation, like nitrous oxide, or through IV injections. So when this says reversible CNS depression, that means it depresses the nervous system, your consciousness, your breathing rate, and even your heart rate, and you're unconscious. So that's why you sleep all through the surgery. As long as they keep the medication going, slows down your other body systems, and it makes it safe for you to have the surgery. Local anesthetics are localized to the site of the administration. So this could be like a local numbing agent, like a lidocaine injection, like into the skin or into the surface, like a transdermal patch, intra-articular injection for arthritis in the joint, or even nerve blocks and spinal blocks. Because in nerve blocks, they'll give you the medication directly into the nerve, and everything that nerve controls from that point in the axon body down distally will be blocked, and so you won't feel anything. Now you still are awake with local anesthetics. So many surgeries are done with local anesthetics, where they just give a nerve or a spinal block. Probably the most well-known example of these is an epidural, which is given often. Many women will choose to get that during childbirth, and it's an injection through the spine into some of the nerves of the spinal cord, and they don't have pain, and then they can deliver the baby much easier, or so I hear. General anesthetics, you're going to have lingering effects of confusion and tiredness, disorientation, maybe some bradycardia. Every once in a while, some people may throw some arrhythmias, more so in the older population than young people. Hypertension is a very, very common effect right after you're coming out of the anesthesia. Sometimes respiratory tract irritation, especially if you had to be intubated, and you can have liver and kidney toxicity from some anesthetics. So what are the implications for PT? Why should you care about this? Well, if let's say that you work in the acute care hospital and you're working with people having surgeries. Well, they're coming out of anesthesia after their surgery, and those residual effects may last 24 to 48 hours after their surgery. So you're going to be doing therapy with them, and they could still have some lingering effects of anesthesia. So they could be confused, maybe occasionally disoriented, probably really sleepy, probably more weak than what they actually are. Maybe some arrhythmias and some orthostatic hypotension. For spinal blocks, they try to make sure that they don't give you therapy for a certain amount of hours, because they know you're going to have severe, but just not permanent, but temporary motor and somatosensory impairments for a few hours after the block. So they're not going to schedule therapy for you for a certain amount of time after that. But if you're coming out of general, they're probably not going to give you, they're probably not going to care much. They're probably going to just say, he's waking up, let's get him going. I'm not going to read you this whole slide is a review of the adverse effects of pain in different bodily and organ systems. And we learned these in semester 1 and semester 2. But I'll let you review this slide. Opioid analgesics. So there's two different types of opiates. There's those that are naturally occurring in our body and in nature, and then there's those that are synthetic, okay, that are made in the laboratory or made by drug companies or made on the street. Naturally occurring ones are endogenous, and they're called endorphins and kephalins. These are the chemicals that that help us feel less pain. If something traumatic happens to us, we may, even though it may be like a broken bone, and we may be in a really bad car accident or something, and we may have a lot of injuries, but that's how a lot of people can sustain massive injuries and not feel as much pain as is proportional to the injuries, is because of our endogenous opiates. So we do make those inside of our body, and we do have cell receptors for opiates inside of our body. The other naturally occurring ones are from plants, especially from the seeds of the poppy flower. And that's where we get our medications, morphine and codeine, from. So believe it or not, morphine and codeine are not synthetic. They're actually naturally occurring. But they are purified before we use them as medication. Semi-synthetic or partly plant-based and partly chemically altered. So like an example of that is Demerol, that used at the dentist. Heroin is also an example of semi-synthetic. And synthetic would be like methadone, that's used to get people off of usually drugs, other things, and fentanyl. There's multiple routes of administration for opioids. The side effects are the most common are always going to be drowsiness and sedation, orthostatic hypotension, almost always respiratory depression, because there are receptors in your brain for opioids, and this does depress the respiratory center of the midbrain. So you do, your breathing rate and depth is depressed a little bit. You may have nausea and vomiting. Chronic use of opioids causes constipation. Too high of a dose can cause disorientation and euphoria, and they are very, very addicting. So for severe post-surgical pain and for cancer pain, Some of the most common ones that you'll see out there are morphine, fentanyl, and methadone. You will probably know Demerol more often by its generic name, not its trade name, but morphine is usually called by its generic name. Mild to moderate opioids include hydrocodone, which can be and there are two different types of hydrocodone. There's Vicodin and Vicoprofen. Vicodin is just hydrocodone, which is a mild opiate, plus acetaminophen, which is Tylenol, and Vicoprofen, which you probably already guessed, is hydrocodone plus ibuprofen. This also includes, they do include oxycodone as a mild to moderate opiate, but in the last this slide is a couple years old. I probably would change this and put this into a strong opiate now, because this is very much one of the opiates that's plaguing our country right now in the opioid epidemic. So opioids, what are the implications for PT? Post-surgery, if you're working in an outpatient ortho clinic or you're seeing people acutely in acute care that are just getting from knee replacements, maybe they had their sternum open for an open heart surgery, a cabbage, anything where they may have been on had a surgery. Well, you got to watch out for any kind of sedation, hypotension, respiratory depression. They're probably not going to have the same physiological response to exercise that they normally would. And they're only really good for short-term pain benefits. This is the typical morphine pump that you all may have had yourself or seen people have in the hospital. And this is just a control pump to where they allow you a certain dosage per amount of time. And you can control how often you get the medication, but once you hit the maximal dosage they allow you, you won't get any more until your new time interval starts. Okay. Now we'll switch to non-steroidal anti-inflammatory drugs, which are also called NSAIDs. These are often over-the-counter, but there are prescription ones too. These provide pain relief. They're often anti-inflammatory. They're anti-fever, and some of them are aspirin is one of them that is anticoagulation, but just aspirin. So let's look at aspirin real quick. It's derived from willow bark. It's naturally occurring. It's anti-inflammatory, anti-fever, and anti-pain. It is where it says irreversible COX-1 and COX-2 inhibitor. The COX-1 and COX-2 are receptors that we have in our body that have to do with the pain signal. Side effects can be gastric ulcers and hemorrhages if you use too much of them, prolonged bleeding, and decreased platelet count from prolonged aspirin use. You can't have sodium retention and edema, hypertension, and this can cause Ray's syndrome in children, which is very, very, very dangerous. And it is permanent, which causes massive neurological damage. So that's why you always see a warning label never to give aspirin to kids. There are also reversible COX-1 and COX-2 inhibitors in the NSAID group. They are very similar to aspirin. And these are going to be things like ibuprofen and Tylenol. You can see that most of their side effects are the same as for aspirin, but these do increase the risk of clot formations. So these can be things like ibuprofen, Aleve, Mobic, or some common ones that I know of, even Toradol. Celebrex is a prescribed medication for arthritis, which is a common one that's been around for a long time. It doesn't have a lot of side effects. As far as GI goes, you only take it once a day. But you do have increased cardiovascular events with that. NSAIDs can delay muscle healing from muscle injuries, and it can decrease bone production for fracture repair. So it's not bad to take NSAIDs like aspirin or Tylenol or Aleve or whatever after a soft tissue injury. It's not bad to take that at the beginning, but then you don't want to keep taking it throughout the healing process because it greatly slows protein production, which is going to, if it slows down protein production, it's going to slow down all the systems healing, but especially muscle tissue healing and bone production and angiogenesis. And you should always use the lowest effective dose. So don't take 4 ibuprofen a week, you can just take 2. Okay, Tylenol, analgesic and anti-fever, but this one has no anti-inflammatory activity. Doesn't affect platelet aggregation or clotting. Not associated with GI ulcers or hemorrhaging. Can cause renal and kidney problems. So for NSAIDs and acetaminophen, what do you need to watch out for PT? They can use these kind of pain medicines for longer periods of time than opioids. So they can use these for longer periods of time for soft tissue injuries and bone injuries. There's no sedation or drowsiness with these. If they take these before they come to therapy, they'll probably be able to do more during your session and be able to function more. But we do need to monitor for possible GI symptoms, and we need to make sure that if they are because of their age, if it's a child, we need to make sure that the parent is not, we need to make sure the parent is not giving them aspirin. If they're an adult and they're already on a blood thinner, we need to make sure they're not taking aspirin too, because that could further thin their blood. Okay, the next type of pain relievers NSAIDs or pain relievers with anti-inflammatory properties are called glucocorticoids or corticosteroids. These are very potent anti-inflammatories. They are prescription-based. There are many different routes of administration, and they're usually used to treat autoimmune disorders and COPD, and significant flare-ups of pain, like with inflammation, like in fibromyalgia and in MS pain. They're only appropriate for short-term use, but some of those that you may have heard of before, actually all of these are very common. The cortisone, prednisone, methylprednisone, and dexamethasone. Those are all very common generic names that you'll see out there. Cortisone can be given as an injection, or you can use it topically. You can buy it over the counter. Prednisone is often used in lung inflammation with people that have asthma or COPD. Same with methylprednisone, usually used by a lot of people. It's a steroid used for COPD. And dexamethasone is an anti-inflammatory that's really common, that we commonly use with ionophoresis. They're only good for short-term use because they have a lot of side effects. They can cause myopathies and tendinopathies. It can cause reduced bone density, weight gain, hypertension, hyperglycemia, GI bleeds. If this is taken in kids, this can cause growth impairment and delay puberty if they're taking these for, like, say, cancer, for inflammation during their cancer treatment, and they're taking them for a long time. Can change long-term use can cause mood changes, cataracts, glaucoma, immunosuppression. Lots of stuff. So not good for a long time. What do you need to worry about for PT? Well, those myopathies and those tendinopathies, especially, don't be easy on your stretching, because you don't want it. They're going to be more at risk for soft tissue tears. Watch out for high impact activities because of decreased bone density, and watch out for hypertension, especially. Okay. This is, if you want to, I'm going to pause the video here. If you want to take a little break, we're going to go into muscle relaxants next. And then, I'll pause the video and then we'll start right back up here. Oh, I did the wrong button. Okay, we'll pick up the video again now. So let me share my screen and we're going to start on muscle relaxants. Okay, next. Okay, so you all remember what spasticity is. It's due to a damage to the spinal cord or the brain, and it's always an upper motor neuron lesion. So you're going to have exaggerated muscle stretch reflex, exaggerated DTRs. You're going to have unwanted movements like dystonia. You're going to have increased resistance to passive movement. So like if you go to stretch them, there's going to be resistance there in the muscle. So here, one common spasticity med is called baclofen, and baclofen is the name it most goes by. It's used, a lot of spinal cord injuries use it, MS, TBI, and some stroke patients, but mostly SCI, TBI, and MS, and a lot of kids too for CP. This is a really good medicine for spasticity and dystonia, but it can be taken two different ways. It can be taken orally or intrathecally straight into the spinal cord through the meninges. So if you take it orally, which they'll always start you off on orally, it can cause drowsiness and dizziness. It can cause you to feel weak instead of hypertonic. Then you'll have muscle weakness, maybe some ataxia and some blurred vision too. Now that's if you're on the high enough dose. Now think about this. You might think, well, maybe they end up, for spinal cord patients, a lot of times they take it and they get used to it sometimes. But think about if you have MS or you have a TBI or you even had a CBA, you probably have some impaired cognition of some sort. So we don't want to put those people on a medication that's going to make them drowsy and dizzy and ataxic, because now they're going to be even more out of it. So if oral medication does help their spasticity, they'll get a trial for an intrathecal pump and then get a pump implanted into their body. And what it is, it's called intrathecal. It actually is a little hockey puck shaped. It's about the size of a hockey puck, maybe a little bit smaller, but it is implanted into your abdomen and it's filled up with liquid baclofen, okay? And then it's implanted under the skin or under the fat. And then a catheter runs up under your skin all the way to your back, and it goes in between two lumbar spinous processes. It goes through the foramen, the nerve root foramen of the lumbar vertebrae, and then it goes in through the meninges and then goes into the space and the liquid around the spinal cord. So like the intracranial fluid that flows down through the spinal cord. Okay, it's delivered directly to the spinal cord. So there it goes directly to the nerves and acts on the nerves to cause decreases in spasticity and dystonia and the hypertonicity. And you don't get any of the drowsiness or the side effects. There would be no side effects because it didn't have to go through your whole bloodstream to get to your muscles and to get to your nervous system. It just went straight to your nervous system. Those pumps are programmable, and they program them through a Bluetooth little handheld device, a little bigger than a smartphone. and they can change your dosage at any time with that device. You do have to get it refilled once or twice a year, depending on what your dosage, and they do that with a needle. The intrathecal pump is made of metal. It's a metal disc, but it has a little port on it that a needle can come through, and that needle, they feel of the pump on your skin, and they can feel the port. They stick the needle through there, pull out what's left, and then fill it up with fill it up with new fluid all the way, and then reset the computer to your settings and your program, and then you're good to go. So it's really, really a good thing. Y'all will see that a lot out there. If you ever see somebody that's got a little bitty knot on the side of their lower abdomen, it's an intrathecal baclofen pump. A lot of kids have that. So if you work in pediatrics, you can see those a lot. Dantrium or dantrolene sodium is also a muscle relaxant, but it does cause general weakness, and it can cause liver toxicity. Valium is sometimes given, but it does cause a lot. It is good for spasticity and spasms, but it's very, very, very sedating, and it is very, very addicting. Gabapentin or Neurontin, you might want to know both of those terms. They're the same medication, just two different names. This is actually a seizure medication, but it can be used for spasticity in MS and SCI. And gabapentin and Neurontin, a lot of amputees will take this for phantom pain and phantom sensations. It does give you a little bit of sedation and fatigue and dizziness, but nothing like the dantrolene sodium and Valium do. So a lot of people may stay on these, and some people might even be on this and intrathecal baclofen, oral or baclofen. All of you have heard of Botox in the last few years, or Dysport. Dysport is just another brand name of the same grade of toxin, the type A toxin. There's three classifications of the toxin, type A, B, and C. Type A is what's most not commonly used in the medical field and cosmetically. B and C are also used sometimes, but they're not as pure and they're not as dosed well or understood. So most people stay away from those. But it actually is from a bacteria that causes botulism, and that can kill you if you ingest it. But when that toxin is injected into muscles, it causes relaxation of spasms, relaxation of dystonia and hypertonicity. If people are having just wherever their spasms are, you give the injection into that muscle. So it only lasts about 3 to 6 months. 6 months is kind of stretching it. Usually about 3 to 4 months is about as long as it lasts. And then you got to get it redone. And some people may get it every 3 to 4 months for like calendar clockwork for the rest of their life. Many people get it for a few years in their spastic muscles, and then over time, the spasticity gets lighter and lighter, and they get stronger and stronger and more functional with their body. And then the thought is their spasticity may be getting better, or they're functioning better because of neuroplasticity, and now neuroplasticity is taking away some of the spasticity. So different places to fault there. Side effects can be general muscle weakness if too much is given, but that typically will go away. You can have some trouble swallowing if you have the injections around the neck. The only time you would have the injections of Botox in the neck muscles is if you have cervical dystonia, where you have you literally develop a problem controlling your neck and head movements, and your head is always rotating or extending or flexing or side bending, and it can be very, very painful. And it's actually a lot more common than what y'all think, but it happens. When it happens, it's often idiopathic, and sometimes it happens after like whiplash or a neck injury, but it's often idiopathic, and it just kind of happens. Kind of sad. If people are getting it around their perineal area or their pelvic floor, it can cause incontinence. It can cause respiratory depression if given around the neck, but only if you get a large amount. There is a possibility that you can develop immunity over time, but I've only seen that in one person ever in my life. I used to help one of my bosses dose Botox patients for my patients. So I would tell her, my so-and-so have some spasticity here, here, and here, and it's affecting us this way. And after we worked together so long, and I knew her dose, what she liked to give, and she knew me enough and trusted me, she would ask me, how many units of Botox do you think we should give in this muscle and this muscle? And over time, we trusted each other, and we worked together, and we kind of figured people out really, really well together. So that was actually kind of fun. She gave me a lot of leeway. And that's probably not something that you should ever tell people that I did. Here's for your chart slide for your information. Other muscle relaxants, benzodiazepines, like ours already talked about Valium, really a psychiatric medication. It does cause muscle relaxation because it does inhibit the alpha motor neurons, but it causes a lot of CNS depression and sedation. So it's really just used for acute muscle spasms and like acute muscle strains, not anything that somebody's going to stay on. Let's see, out of this slide, you might want to know the terms Flexeril and Scalaxin. Those are other muscle relaxants that are out there. They're used a lot of times for musculoskeletal injuries. They can cause dry mouth, sedation, some dizziness, and that you can build a tolerance on these. So what do you got to look out for when people are on muscle relaxants? Sedation, hypertension, maybe some bradycardia, maybe some disorientation, maybe a little bit of confusion if they've already got some cognitive impairments from their injury and now the medication is doing it on top of there. If they're getting intrathecal baclofen or Botox injections, maybe, and they're maybe they just got their Botox injections and it's fresh, or they just got a new dose up in their dosage on their pump, then maybe they're a little weaker than normal and they've got to learn how to function in that new amount of strength. Okay, going into cardiovascular pharmacology. This is nothing you don't know. I'll let you read this. All these stats, you know, on hypertension, and the consequences of hypertension. There's a lot of different kinds of antihypertensive drugs out there. These are all the categories, and we are going to go through each of them one by one. And I'll probably just give you a couple to try to remember, and I'll let you know which ones to remember. Usually people are on more than one of these to get their low blood pressure goal, but they're often overprescribed and can affect people's exercise tolerance quite a bit. So diuretics are if you see the UR in it as it does exactly what it sounds. It gets rid of water and gets rid of fluid volume in our body. So we're always urinating a lot of it out. The most common one out there by far in the world is called Lasix. Not the Lasix you get for your eye, but it's a pill called Lasix. It's usually the very first thing that they try. It's very, very for blood pressure, even when somebody's just getting diagnosed or has low borderline high blood pressure. It's very effective and it's very cheap to make. Decreases fluid volume in the body, so that makes the blood pressure go down. Decreases cardiac output, so the heart isn't working as hard, so that decreases the blood pressure, and decreases peripheral resistance too. Side effects can be, since you're getting rid of so much fluid, you can have some hypernatremia, some hypokalemia, if you remember those from the lab value lesson, and they can cause sometimes arrhythmias. sometimes fatigue, and osteoporosis, sometimes if they're with other types of diuretics. Beta blockers are mostly affecting the heart. They're also another one that's often another common first-line therapy. Beta blockers, they decrease your heart rate and your contractility, so how hard your heart beats. So if it decreases that, it's decreasing your cardiac output, how much blood you put out, and it decreases peripheral vascular resistance, so it causes vasodilation. They use this really commonly with high blood pressure, also angina, and after heart attacks, people that have arrhythmias or maybe be diagnosed with heart failure. Some of the most common two out there are going to be low pressor and Enteral, and they're often also known by their generic names as metoprolol and propranolol. Sorry. But they do have some side effects, so they can cause you to have some bradycardia, so too low of a heartbeat, and some orthostatic hypertension. That's the one that I've seen the most common, is too low of blood pressure. So they go on a medication because they have high blood pressure, and then their blood pressure is too low to actually work out or exercise. So it's kind of ironic. Sometimes depression and fatigue, sometimes some sexual dysfunctions, big time change in cardiovascular response to exercise. They're going to be exercising or doing aerobic exercise or weightlifting, and their heart rate and their blood pressure are not going to respond in the same way that normal people would off the medication. Can cause bronchorestriction. What do you need to watch out for? Oops, hold on, where'd I go? There we go. Implications for PET. Well, I think the big thing is going to be, if you just look at the side effects, is going to be the low heart rate and the low blood pressure and the bronchorestrictions. Those are going to be the biggest ones that affect us. And if you think about it, they're working directly on the heart, so those things make sense. Alpha blockers also work on the heart. They work on the cardiac smooth muscle. They cause vasodilation and decrease peripheral resistance. And examples of them are going to be Cardura is the one that I've heard the most of. Side effects like beta blockers, can be orthostatic hypotension and maybe reflex tachycardia. ACE inhibitors, also short name for angiotensin converting enzymes inhibitors. They block the conversion of different angiotensins that are very potent vasoconstrictors, and they cause peripheral resistance to go up. So if we inhibit these enzymes, then we can cause reduced peripheral vascular resistance, so we have peripheral vasodilation and decreased heart output, decreased cardiac output. Can cause renal disease. I'm sorry, it's not so bad on the kidneys and the liver like other ones are. It can cause a dry cough. It can cause edema and hypertension. And the most common ACE inhibitor is going to be lisinopril, and that's the name that I know by the most of, is lisinopril. So if I do include this on test, which who knows if I will or not, then I'll use lisinopril as the name. Angiotensin receptor blockers. These are going to be block receptors that bind the angiotensin 2. They are very, very similar to ACE inhibitors. Calcium channel blockers, they block calcium from entering into the muscle cells of the heart, and we all know that calcium is necessary for any muscle contraction. So if you don't have as much calcium coming in to the heart muscles, then you've got decreased cardiac output, then you have vasodilation and decreased peripheral resistance. They use this a lot with people that have different stages of angina, that have diabetes, and them that have arrhythmias. The side effects can be edema. You can have a short-term risk of MI, heart attack. Again, orthostatic hypotension, constipation, headaches, necks, and dizziness. What you gotta watch out for anybody on an antihypertensive, pretty much the dizziness, the orthostatic hypotension, and their heart rate not responding. Well, their heart rate and their blood pressure not responding the same way to exercise. Okay, let's talk about lipid-lowering drugs. So these are drugs that lower your lipids, your fat, and your cholesterol. So people that have dyslipidemia, so bad lipids, or high lipids, that have lots of buildup in their arteries. So they're, all this, they're at risk for coronary artery disease, MIs, angina, CVAs, and peripheral vascular disease. So these are the optimal levels of cholesterol. So we have our LDL cholesterol, low density lipoproteins, which are the bad kind. Sorry, my phone's not on silent. And then we have the HDLs, the high density lipoproteins, which are our good ones. And then we have our triglycerides. And you can see here that in men and women, that we both want our low density lipoproteins, the bad ones, we want them to stay less than 100, okay? And then the good ones for men, we want them to be above 40 at least, and women above 50. So for everybody, we want them to stay around 45 or 50. And the triglycerides, we want them to stay less than 150. So if you're higher than those ranges, you probably already got one of those diseases, or you're at very, very high risk. So the most common lipid-lowering drugs are called statins. They decrease lipid cholesterol production in the liver. And they decrease our low-density lipoproteins, and they increase our high-density lipoproteins, our good ones. So they lower our bad ones and increase our good ones. The side effects can be myopathies and increased liver enzymes. So you can have some hepatotoxicity. These are three very common ones: Lipitor, Zocor, and Crestor. A lot more common on TV than they used to than they are now. So angina, what is angina? This is characterized by chest pain that is indicative of cardiac or coronary artery blockage, but not a complete blockage. So the blood's still squeezing through, but it's really, really constricted. So you're going to feel some chest pain, usually with increased activity level. You may have some neck pain. Very common to have jaw, scapular pain, and left arm pain. Like I said, it's aggravated by physical exertion, emotional stress. Usually lasts for 30 seconds to a few minutes, up to 20 minutes. And it's pain there because the oxygen demand for the heart is exceeding the supply, because you've got one or more coronary arteries that are partially blocked. Unstable angina is when you have pain at rest, but it's not a true heart attack yet. But if you have unstable angina, you probably are going to have a heart attack any day now. So to prevent angina and heart attacks, you just want to take some aspirin, or if you're having them, if you have angina, you're going to be on aspirin, for anticoagulation and pain. You're going to be on beta blockers for your blood pressure. They're going to tell you to stop smoking. You're probably going to be on statins for your cholesterol. You're going to be on a big diet change and a lot of education about your diet and exercise. And it's really going to be a big lifestyle change. Just about everybody that ends up with angina or survives a heart attack, they do make big lifestyle changes afterwards. Or if they don't, then they have another one. They're all, like I said, they're on antithrombotic therapy to prevent clots. So aspirin is a common one, statins help, and ACE inhibitors help. Plavix is a common one that you need to know. Plavix is a common antithrombotic. Nitrates like nitroglycerin are the most common anti-anginal pain. They're usually given in a form that dissolves under your tongue sublingually, or it might be a transdermal patch. But nitrates often cause headache and dizziness, and sometimes a very fast drop in blood pressure. Also, people that have angina may be on beta blockers to decrease their heart rate and cardiac workload. You can see those side effects, which would be obvious to you. Calcium channel blockers also vasodilate form, so it decreases their cardiac workload. So people that have angina are just they're really just a ticking time bomb. I mean, if they have unstable angina, they're having chest pain at rest, I'm not touching them. You better not touch them either. If they have stable angina and they can work, and then they start having pain, well, you stop right then and you rest and you breathe and you maybe take your nitroglycerin, you stop everything you're doing. So you need to know what types of medications they're on and what sets their angina off. Is it heavy activity? Is it light activity? Does the heat exacerbate them? What types of exercises exacerbate them? Heart failure can just result from any structural or functional cardiac change that changes the ability of the ventricles, just the ventricles, not the atria, but the ventricles to maintain the correct cardiac output. So if you do have any degree of heart failure, you're going to have some dyspnea at rest or with this exertion, general fatigue, exercise intolerance, and you'll definitely develop edema, most commonly in the feet and the ankles and the lower legs. Classes of drugs they give heart failure patients. ACE inhibitors, diuretics, beta blockers, vasodilators. I mean, anything to just cut down on that workload of the heart and decrease peripheral resistance so that everybody is happier. Everybody works less and everybody's just working a little bit slower. So you can see those side effects, which we've mostly went over in the hypertension section. One thing here is that the inotropic agents. Some of these examples are like digitalis, digoxin, digitoxin. These are very specific heart failure medicines that you need to be familiar with. They work because they actually increase cardiac output, but they enhance the contractility. So they make every contraction of the heart more like every contraction has a higher quality and amount of blood that it pushes. So it's enhancing the heart a little bit. So it can work a little bit better. Implications for PT, need to be aware of dyspnea. I mean, that's the biggest thing. That's one of the big things in exercise and increasing exercise intolerance and cough. You need to monitor their peripheral edema, especially in their lower extremities, and check their blood pressure. I mean, 2 or 3 times a session. Let's look at coagulation disorders. So we'll look at underclotting and overclotting. So we learned these drugs, or these classes of drugs, back in the, I believe it was the lab value section. So I'll let you see those. So acute treatment is heparin, is one called heparin. Long-term prevention for clots is called warfarin or Coumadin. We went over these a little bit, but heparin is more of immediate effect. So if they find a clot like in your leg, or they find a clot in you, they're going to give you a heparin injection, and you can resume your normal gait activities and be up and walking around within 4 to 7 hours. Other than that, you need to be in bed flat, not moving. But within 4 to 7 hours of a heparin injection, you can have, you can be up and going. But a side effect, if they give you too much, could be a hemorrhage or a low platelet count. Warfarin or Coumadin is a much longer term prevention of clots, but it takes several days for it to start working. It is a pill, and you have to get your INRs and your platelet counts measured like at least every 4 to 6 weeks, I believe it is. Maybe it's 2 months, but I know it's very regularly, like at least every month or two. So that's one. Coumadin is a good drug, but that is one of its big downfalls. So you got to get your blood checked all the time. Let's see what we have here. The new drugs out there for clots they're taking the place of Coumadin and warfarin, or these two at the bottom, called Pradaxa and Xarelto, starts with an X. Those can be taken every day for clot prevention, and you don't have to have any blood monitoring done. So the newer ones are much more popular and much less problematic to take, and there's more compliance on the new ones. Antithrombotics that are used to treat TIAs and ischemic, CVAs and MIs. Remember TPA. And Plavix does that too for ischemic events. Plavix is going to be a more long-term, where the TPA is going to be more for stroke prevention, maybe MI prevention within a few hours of having the symptoms. Thrombolytics. Here's TPA I was talking about. Overclotting treatments. So if somebody is on a treatment to control their clotting, what are some things we have to think about? Well, let's see. They're going to be at increased risk for bleeding internally or externally. So even during just regular exercise with us, if we're doing mobilizations or deep tissue work, some like deep tissue, like on trigger points, or we're doing some instrument assisted, we try some instrument assisted STM on them, we're going to make these people bleed out the wazoo. So be very, very, very careful with people on clotting medications, on anti-clotting medications, whenever you think about doing joint mobilizations. You don't want to do any deep tissue work, and you especially don't want to use the IASCM. And they're going to be very, very susceptible to bruising, even just by getting bumping their arms on the wheelchairs, maybe just by pushing or lifting too many weights with you, or even just pushing against a weight machine can give them a bruise. Okay, and that is all. So I know I ran through a lot. That is a lot, and I hope that you can at least look at the PowerPoint that you've been provided with my explanations on the video, and it will hopefully you can remember the implications for PT, because that's the most important thing I want you to get out of this lecture. Okay, so thank you, and we'll see you all next time in lab or on Zoom.